Hi, everybody, and welcome to the BioExclude Corporate Forum here for the AAOMS 2021 Nashville meeting. My name is Michael Hartman. I'll be the presenter today. First and foremost, I would like to thank BioExclude for entrusting me for presenting their corporate forum. I was very excited when they asked, and I think we can have a lot of fun with this topic today in this presentation. The presentation you're about to hear is loosely inspired by the Dr. Seuss children's story, Oh, the Places You'll Go. I don't know if it's because my oldest son is just turned senior in high school and he's about to embark on college, and the rest of his life, it got me thinking about Dr. Seuss. But I think this book actually relates rather well to BioExclude from the standpoint of all of the various applications that I've been able to use the BioExclude product in my practice, and that's what I hope to share with you today. So let's get started. Congrats, you've been processed and we've gathered a crowd. Yes, we are in person and we may get loud. Sorry we had to film this part virtually, but hopefully this will come off a little bit better in the in-person format. Let's not discuss who has received the vaccine. Let's not discuss who's had COVID-19. We are here for your story, the story of you, the one they call BioExclude. For those of you who aren't familiar with BioExclude or have had the opportunity to use it before, let me tell you a little bit about it. It is a de-epithelialized, dehydrated amnion chorion membrane. This is harvest from the live cesarean births of humans. And once it's done being processed, it's essentially the two layers of the amniotic membrane. It's the outer amnion layer as well as the inner chorion layer. And these two layers combined have unique properties that not only give it ideal characteristics for placenta linings, but also a lot of ideal characteristics for a regenerative product, especially for the oral surgery procedures that we use it for. The reason it does this is because it has various types of collagen in it, is in both the amnion and chorion layer. It also has other properties called laminin and fibronectin. And these collagen types and the laminin and the fibronectin, which are embedded in these two layers, give it this, what's described in the literature as a viscoelastic type property. So it essentially will stretch, it can be manipulated without tearing or breaking, which is one of the properties that I look for in a membrane that I like to use. The placenta or the amniotic membrane, once it's done being quarantined and being tested for communicable diseases, undergoes this proprietary BioExclude process called Purion Processing. And this is a process where through gentle washings, the cells and the debris of the membrane are removed. The epithelial layer on the amnion is removed, the spongy layer that is between the amnion and chorion layer is removed, and then these two layers are then laminated together and dehydrated into the membrane that we know and use. And why this Purion processing is important is because it allows the growth factors and cytokines and inflammatory mediators to still be intact in this membrane, even through the processing portion. And you'll see later why this is advantageous. Here's a brief schematic then, anatomical layers, if you will, of the amnion and chorion, showing how the epithelial layer is removed. This exposes the basement membrane of the amniotic layer. And why this is important is this allows the host cells to embed in this membrane and start to proliferate. You'll notice that on the membrane itself, there's always a smiley face that's stamped, and this smiley face is always stamped on the amnion side. Now, it was initially thought when this membrane was first brought in to use that it would matter whether or not the amnion layer was face side up. But this has turned out to not matter at all. So in fact, you can put this membrane in either way, smiley up or smiley down. It doesn't matter. This is probably one of the most important slides of the whole presentation, and I'm going to tell you 3 reasons why I think this slide is so important. Reason number 1 is the membrane itself is resorbable and immunogenic. So what that means is that the host does not mount an inflammatory response once it's placed, and this helps decrease the amount of postoperative discomfort that patients are in after a procedure with this membrane placed. And this has been shown to reduce the amount of postoperative discomfort when compared to a comparable membrane, say the non-resorbable PTFE membrane. What I like about BioExclude, reason number 2, is that it comes in a variety of sizes. And you may think that this is overkill when in fact it's not. I typically don't have all these sizes that I use in my practice, but over the last 5 years that I've used the product, I know the sizes that I tend to use more than others, and I can keep these in stock. And these membranes vary significantly on their price point. So I think that is a unique advantage. So for instance, I don't have to pull a 20 by 30 membrane just to cut it down to a 12 by 12 size. It's very versatile from that perspective. The third reason that I think this slide is most important, and the reason that I think makes BioExclude an amazing membrane, to be honest with you, is the fact that it is embedded with all of these various growth factors and cytokines and cell mediators. And if you look at the BioExclude cartoon on the left here of the page, he's got his guns up and he's all inked up. And if you look closely at those tattoos, you can see that those are some of the growth factors that's been found to be present in the membrane. For instance, you have TGF beta, you have EGF, you have PDGF, you have the beta FGF, you have various growth factors and various cytokines, a relative or abundance of alphabet soup of growth factors and mediators, if you will. So let's get on to our next chapter, and I'll share with you the various indications that I've been able to use BioExclude in my practice over the last couple of years. You've got lots of good stuff, lots of really good traits. So let's tell the doctors just where you can be placed. First, let's see why you're a sensation when it comes to guided bone regeneration. This was initially why I was attracted to BioExclude, the fact that you can use this in, say, socket type preservation procedures. And what I like about it is you can leave it exposed. You don't have to raise a flap and close it primarily. It does just fine in an instance like this. You can see this is just a standard case for its use. There's a upper molar that has multiple abscesses on it. I extracted the tooth, cleaned out the abscess, and then we packed this with some allograft material. A lot of times when I use BioExclude, I'll typically use the 10 by 20 for these site preservation procedures. A little neurotic in that I like to raise a little bit of a buccal in lingual or palatal flap. And you can see from the photo, even when I'm in the posterior, I try to make these papilla sparing to preserve as much tissue around the adjacent teeth as possible. I'll take my periosteal elevator and raise a flap about 3 or 4 millimeters. And why I like that then is it allows me to kind of snug that membrane in on both sides. You can use either chromic suture or PTFE suture to place over the membrane to secure it. I honestly prefer chromic a lot of times. I think the downside to that is it does tend to be a little bit tacky or sticky, and if it occasionally will catch that membrane and dislodge it, why are you trying to suture it? So to me, that's why I kind of prefer the 10 by 20. If I get it tucked on both sides, it tends to stay intact and not move on me when I do the suturing. See this kind of complicated suture here, that there's a lot going on. It's really not that big of a deal, to be honest with you. Typically use what they call inverse figure 8 suture. So I'm starting from inside the flap and working out and crossing over the socket a couple times and then tying that off. And the inverse figure 8 suture helps prevent dislodgement of your membrane when you're suturing. Typical result here at 3 months, we have nice graft consolidation of the allograft, and this case actually turned out very, very nice in terms of the occlusal soft tissue that we were able to regenerate or heal in that site. Now this patient is ready for their implant workup and implant placement. As I got more familiar with BioExclude, I started to use it for more expensive graft type defects. And you can see now we're onto a 4 bony wall defect here in the anterior maxilla. There's a large amount of granulation tissue and abscess at the bottom of this central incisor. And once it's debrided, you can see I just have a real thin rim of bone remaining at the alveolar crest. And why I chose really to document this case so heavily, as you'll see, is the amount of exostosis or buccal prominence around the alveolar crest. And what made this case really fun or somewhat unique was I was able to graft right up to this exostosis, ensuring that I would have a large amount of buccal bone to prevent resorption from my eventual implant placement. This is the case I did a few years ago when I was still using PRP. So we mixed the PRP up with the allograft to make sticky bone and condensed and applied it over there, feather in the edges of the exostotic bone. The membrane itself, when you take it out of the packaging, is what I would describe as almost crispy, if you will, but not brittle. And what I mean by that is you can still handle it. It doesn't tear that easily. You can cut it with scissors. It's fine. It'll cut very easily. And this is sort of kind of a common way that I utilize the membrane and the anterior maxilla. I typically use either a 15 by 20 or a 10 by 20, kind of knock those edges off it, if you will. I like to take the membrane with the cotton forceps, and I want to grab that pretty low on the membrane. And in this case, since I dropped the vertical release incision, I'll use my Adsons with teeth to gently reflect my flap. Then I'm going to bring in my membrane with the cotton forceps from the releasing side incision, side into the deep side, if you will, and seat it securely. Now, a lot of times then I'll take a periosteal and sort of tack that membrane in position through the overlying soft tissue and gently remove the forceps, and a lot of times the membrane will stay intact. Once it's in place, as you can kind of see from the middle slide, you just need to hydrate it either with some PRF solution or Sarah water, whatever you have. If you just take a dab of it on your periosteal, it hydrates very easily, and it gets to be in the consistency of what I would call kind of like thick saran wrap, not the annoying saran wrap that it bunches up on you. You can't sort of unwrinkle it. This kind of like the it's not the generic saran wrap. It's like the cling wrap. You know, you pay the couple extra dollars and you get the nice cling wrap that kind of doesn't bunch up. So you're able to iron this out, fold it over the crest. If it's a little bit out of position, it's easy to manipulate back into the spot that you want. It doesn't tear, it doesn't rip. It's a very durable membrane, and remember, it has these durable qualities from all the various different kinds of collagen and laminin and fibronectin that it's composed of. The closure on the right side is what I'll do sometimes in the anterior, where it's a little bit of a bigger flap, so I don't want the chromic suture to resorb. I want something non-resorbable, so I'll use the PTFE over the occlusal aspect of it, but typically close the vertical release with the chromic suture. I find sometimes it can be challenging to find those little knots of the PTFE, and it can be very uncomfortable at that 2-week mark to remove that from the patient. I don't typically see my patients on post-op day number 1. It just so happened that this patient forgot his Essex the day of surgery, so he had to come back in and have that inserted. I took that opportunity to take a photo, because we don't get to see them really at all on post-op day 1. See that the area is already starting to heal. There's some fibrin, blood clot that's over the exposed membrane portion, and you can see that on post-op day number 14 at the 2-week mark. The vertical portion of the incision is healed very, very well. The socket portion is still healing. The new tissue is granulating in. There is still membrane over it at this point. I will tell you, it's very thin, it's very translucent, but it's still doing its job in terms of acting as the graft holder, graft containment. And then we document on our 3-month mark, and we have very nice soft tissue, and as well as the post-op CT on the upper right corner showing a well-condensed graft ready for implant placement. A little bit more of a severe type defect here on, again, another maxillary tooth showing complete erosion of the buccal wall with a rather extensive abscess from the tooth. Same sort of procedure here, where I use a vertical release incision to ensure that I had appropriate access to the area to allow thorough debridement. This is a grafting technique that I took a little bit differently, however, because I didn't have the exostosis of the previous patient to really expand or augment or widen that buccal bone. In this type of case, I'll typically use two different graft materials, and in this one I used a half cc of allograft made sticky bone out of that, and I primarily packed that in the socket itself, and then I like to mix up a separate sticky bone mixture with a xenograft material. And what I like to do is kind of lay that flat on the vial and use my large bone graft packer, you know, the one that kind of looks like a meat tenderizer, and I try to tamp that down and make that as thin as layer as possible, because I like to apply that to the buccal exterior of the graft, and I'll go ahead and place my BioExclude over the top of that and close that. And you can see the closure here on the left page, if you will, the same thing, the PTFE, because I don't want this to open early. There's a fair amount of graft material here. Then I ran the chromic up the vertical release then, so that I didn't have to fish that out at the post-op appointment. So there's advantages and disadvantages, I think, to this technique, and let me tell you why I used it in this particular patient. 2 reasons being that the patient had a low smile line and a very thick gingival biotype. I like using xenograft material from the standpoint that it's very, very slow resorbing. It tends to maintain its consistency and not turn over to mature bone for 5, 6, 7 months, depending on the actual xenograft material that you like. Now, I don't typically like to wait that long to place my implant, so I still like to use the allograft in the socket itself. So this, to me, gets me the best of both worlds. I'm able to preserve or prevent that resorption of the buccal wall, but still be able to perform my implant surgery at the 3-month mark. What you will see is, if you're not familiar or haven't used xenograft grafting before, is a lot of times you'll see some spitting or dehiscence of that graft material, as you can see on the picture on the right page. And this isn't too uncommon, and this really isn't anything to worry about. What you do need to be aware is that if you're planning to use xenograft material on patients with a high smile line and with a very thin gingival biotype, you may run into areas where you have some buccal dehiscence and exposure of this graft material. Now, I've had this once or twice. The graft itself didn't fail per se, and it didn't become infected, but it was rather challenging to explain and treat with the patient until it resorbed and tissue grew back over. So those are reasons why I tend to stay away from it on those particular patients. It's a bigger defect here now. We're getting into 3 4-wall bony defects where we've removed the remaining anterior teeth. We're a little shy horizontally in terms of what we need for augmentation. The vertical height was good, so I ended up putting some horizontal tenting screws in to help prevent rapid or too much pressure, if you will, on the buccal tissue. I mixed this was actually just a straight allograft that I used with PRP sticky bone. And I put 3 20 by 30 membranes over this to close it primarily. And I was very happy with this result, and I'm sharing this particular slice of the CBCT with you because I think it demonstrates that we maintain pretty much all of our graft that we put in. You can see the 2 horizontal tenting screws on either side. They did not dehisce to the tissue, and you can see the graft materials right up to the head of the screw. So those are sort of various ways that I started using BioExclude with our guided bone regeneration, and now let me show you how some of the other ways we can do it next chapter. But there are a few, Hartman, Cullum are 2. They don't like to delay. They like to place lots of implants on the same day. Do they need a membrane like you? A membrane they call BioExclude. For those of you who have heard me talk before, I'm a huge fan of X-Guide and dynamic navigation and the restoratively driven treatment planning ability that it gives you. And before I get to some of the cases, I want to share with you 2 slides here why I think XNav makes me, at least, or allows me to provide better case outcomes for my patients. The first was a study that was done by Dr. Block and Dr. Emery years ago, demonstrating the accuracy or angle of deviation that you can accomplish with dynamic navigation versus the traditional freehand method of implant placement. So what they found in their study was the average degree of angle deviation when using XNav to place dental implants was 3 degrees. They also found at the same study that the average angle of deviation when performing implants freehand, or the traditional method, was 7 degrees. Now, it may not seem like 4 degrees is a big deviation or big difference between those 2 groups, but if you look at the cartoon that I had made below here to demonstrate that, it actually can make a difference. And the first cartoon on the lower left is showing the yellow line where our implant has been planned in our virtual treatment plan. The second, or the middle shot, is showing a 3 degree deviation strictly to the buccal in this case, and then the third cartoon, it shows a 7 degree deviation strictly to the buccal. And this would be something that you would expect to obtain if you're placing your implants freehand. So if I'm navigating my implant, and if I'm having a decent day, and if I'm within the normal 3 degrees of deviation, if my 3 degrees is tip buccal, you can see that my insertion or my eventual screw access path is still going to be within the central fossa of the teeth. And it's really beyond my expertise, if you will, to dictate to my restoring colleagues and to their dental technicians in terms of how these implant cases get restored, say for a single unit. I feel like it's my job to set them up for success by giving them options. And in this case, I've given them the option to either restore this single implant with a screw retained crown, or if they like, a cement retained crown. They both have advantages and disadvantages for sure. If I'm in the freehand group and if I deviate 7 degrees towards the buccal, notice where that red line then ends up. That's ending up through the buccal cusp. So this is probably not a restoration that would be amenable to a screw retained prosthesis, and this one is going to be relegated to a cement retained crown, and that may be what the doctor and the technician decide to do. However, they essentially don't have any options if I'm off 7 degrees and tipping it buccal. Now, we can take this concept of dynamic navigation or accurate place implants with our X-Guide one step further. And this study explains a lot in terms of how I practice implant dentistry. And this was what I feel was a nice study done by Dr. Chu and his colleagues a few years ago, where they were analyzing the Peri implant soft tissue is 4 different implant groups. These were all implants that were placed immediately in the anterior aesthetic zone. First group A had the immediate implant placed with stock healing cap. The second group B had the immediate implant placed with an immediate provisional. The third group C had a immediate implant placed with a bone graft in the buccal graft or buccal jump site, if you will, as well as a stock healing cap. And then the last group, group D, had the implant placed, the bone grafting on the buccal, and immediate provisionalization. So at the time of final restoration, when they took their impressions, they measured the soft tissue around the implants in a facial palatal direction, not only in thickness and in height, and they found that group D, the one that had the immediate implant, the bone grafting, and the immediate provisionalization, had the greatest amount of soft tissue height and thickness in the facial palatal direction. So what that means to me is that you're going to achieve better outcomes of your soft tissue when you're using an immediate provisional versus a stock healing cap. And I think you can extrapolate the study out one step further and say, if you use a patient-specific custom healing abutment that is based off the anticipated final restoration, you will still have this greater amount of peri implant soft tissue. Because remember, the provisional, the part here that's really contouring the soft tissue is just that apical third of the provisional anyway. And I think we all realize at this point that majority of teeth do not have a circular dental anatomy at the CEJ, and I think striving to recreate a realistic emergence profile is something that we should be doing on all of our implant cases. So let me walk you through a standard case here where I'm able to implement these 2 studies that I just shared with you. This is a non-restorable fractured tooth number 8. We're setting this up in our X-Guide virtual treatment planning software. We're planning this in a restorative-driven manner, meaning the screw access hole is going to be intended to be coming out through the cingulum. Now, this case, to me, sets up very nicely to do an immediate provisionalization on, because I can tell certain things on my virtual treatment plan. First and foremost, I have a fair amount of bone apical to the apex of the root. So I'm planning to have a pretty good primary insertion torque here. What you can't see on this screen, because I hid the opposing intraoral scan, is that the patient's bite is a minimal. He doesn't have a very deep bite. So I feel like I can fabricate this provisional and keep it out of occlusion and have success with this during the integration process of the implant procedure. So once I finalize my XNAV plan, I'm able to take that virtual information and export it out and import that into dental CAD/CAM software. And once we have that information in our dental CAD/CAM software, we are using that implant position as if it has already been placed. And that allows us to design and fabricate the provisional even before we go to surgery. And you'll see the picture at the top here is our provisional that we've made before the procedure. So this is sitting in our lab box here before the case starts. And what makes this very nice is we've been able to design and fabricate this in the dental laboratory. So this has all been benchtop process. We don't have to worry about picking this up at the time of surgery, say using the shell technique, or we're trying to finish the margins. This is good to go. And if I'm having a decent day here and am navigating within a relatively good sphere of accuracy, I'm placing my implant pretty close to my intended virtual plan. You can see on the lower left picture, I'm in the position that my virtual treatment plan says I am in, but in this case, I'm coming up maybe a millimeter or two shy in terms of the buccal wall. Now, I could go ahead and place this perhaps a little bit deeper, but I'm afraid that this may be a contour issue, hygiene issue later on. So I decide to leave it as is and just place a little bit of allograft, not only in the buccal, the buccal gap, if you will, of the socket, but then put it over that 1 or 2 millimeters where I'm a little shy. Once I've grafted, I'm going to insert my provisional. I'm going to make sure that my timing or rotation of my implant is in the proper positioning so that the provisional goes in rather smoothly. Sometimes you'll have to adjust the contact points on either side. And once you're happy with that, then you can go ahead and screw that in, torque it to whatever the manufacturer suggests. And then I take just a small 8x8 BioExclude membrane, lay that up against the buccal, and then close that with a couple sutures. And the membrane's great from the standpoint that you can go ahead and leave it against the provisional crowns in this case. You can leave it on adjacent teeth roots. It doesn't interfere. It does just fine. And you can see this is our post-op, was this, 2-week photograph here that the tissue is kind of thick and bogging. It started to settle down. Probably not the most aesthetic provisional that I ever did, but again, if you're comparing it to the pre-existing tooth that we extracted, we're sort of on our way for improvement. And a lot of times, especially in patients that aren't super aesthetically oriented with immediate provisionals, you're still providing them a service from the standpoint that you're starting to develop those gingival contours that are going to allow the restoring doctor and the dental technician to develop a final prosthesis that's very aesthetic and hygienic. And you're also saving this patient from having to wear something temporary like an Essex retainer. It's also good, in my opinion, to do immediate provisionals on all cases that sort of satisfy your criteria for immediate provisionals. This essentially gives you practice then for when you're really going to need to do immediate provisionals in someone that has a high smile line, that is very aesthetically demanding. Dr. Cullum wrote a great article on using the BioExclude membrane in terms of around immediate implants in the molar sites a few years ago, and that's sort of what inspired me to start to use it on cases that I just had shared with you. Here we have an immediate molar place again with the X-nav. I think the X guide itself really makes placing immediate implants a lot easier and a lot more predictable. And as I've used the X guide over the years, I would say I've gotten very, very confident in placing a lot of my implants now immediately with the dynamic navigation. In this case, I'm a little short on the buccal again. I'm pretty happy with where I'm at in terms of the lingual wall being subcrustal slightly. So in this case, I decided just to not only pack the surrounding sockets with some allograft material, but then bring that up along the buccal side and place a small 12 by 12 over the buccal, and then secure my custom healing cap and suture it up with a couple chromics. And this works very well. You can see on the 3-month mark after the implant placement, we have integration, and we have a very nice soft tissue response around the healing cap and around the BioExclude membrane. And the BioExclude membrane at this point is well resorbed. And now this patient's ready to be released from our care and turned back to their restoring doctor for final restoration. So let's get into the next chapter here. But sometimes we may on occasion get into a tingly situation. It would be nice if you could help us not pout, for these nerve things can get us stressed out. Yes, there's some evidence in the literature to show that using the amnion chorion membrane may be beneficial for peripheral nerve defects. And this is, kind of one of those cases where I had a big abscess on a second molar, and I'm sort of have the tooth out, and I'm curetting and and I think it almost feels like I'm curetting a rubber band here and not the abscess. And then I kind of stop and sort of got to use my mirror and look in there, and sure enough, it's not abscess anymore that I'm trying to curette out. It's the inferior alveolar nerve. Now, luckily, I had the wherewithal not to use my serrated curettes in this case, and I stopped before I was did any damage to the nerve. We still have this defect to deal with, and I still am a little bit worried about the patient developing paresthesia from the curettage that I already done. So nice case set up to use what I call like a sandwich graft with the BioExclude. I'll take a 12 by 12 membrane, and I'll place that gently on top of the nerve, and that helps kind of seal that area off. And then I'll go ahead and place my allograft material on top of that. I want to pack kind of hard, but not overpack it, because I don't want to put any undue pressure on the nerve and sort of push it down, if you will. This case set up well because the surrounding gingiva was kind of boggy. It just seemed like it might be a good case to just slide another 12 by 12 under the surrounding mucosa, which is what I did, and then sutured this up with a PTFE. And I got my two-week PostOp Panorax, and you can see that it's a little bit of a defect there, because I probably could have condensed a little bit more. But again, I was kind of concerned with the nerve, and what was good to know, or I was very relieved, was that the patient reported no paresthesia. So we're in good shape here then to proceed after a couple months of the graft maturation for our dental implant placement. And again, just a basic X guide case here that we're initially designing our virtual wax up, if you will. You can see that teal colored crown that we've placed, and then we're going to head planning our implant in the appropriate position then for the anticipated final restoration. This is our picture on the left-hand side, showing how the nice closure of the soft tissue in that area. The 3-month post-implant placement x-rays on the right, and then we still use the custom healing abutments even in second molars, and we get real nice soft tissue outcomes. And let me tell you why I think this is still important to use custom healing abutments even for second molars. And number one, your restoring doctors really appreciate this because the custom healing abutment typically flares this tissue out from the implant platform. This makes their lives a lot easier than when they're seeding their impression copings or seeding their impression scans for digital impressions. Second reason I think this is great is because these contours have already been designed or contoured during the healing process, and the lab technician that's designing and fabricating this restoration doesn't have to guess. So he or she is able to design a restoration that is hygienic around the gingival margins and also aesthetic. The last reason why these custom healers are great is when the restoring doctor gets the case back from the lab and goes for insertion, there's no tissue impingement because remember, the technician already knows where the contour is. They don't have to sort of create the contour, and the restorations typically don't pinch as they're being torqued down. And this is something that my restoring doctors have shared with me and stated that's a real advantage to using, say, the traditional stock healing abutments. This is another case that I used the BioExclude and a sort of a nerve regeneration on a very difficult case that I did, and I ended up needing to move or transpose the inferior areolar nerves more distally in order to create more space for an all-on-X type procedure. And once I had the nerves unroofed, before I went ahead and placed some grafting material around there, I wrapped the nerve in these 10 by 20 membranes, and the handling capabilities of the membrane makes it amenable to this type procedure. You can almost wrap it, almost create a conduit, if you will, around the nerve. And again, the patient reported no paresthesia in this case. Next chapter. Oh snap, BioExclude. I meant to lift and instead did a swerve. Can you help me out with a sinus perf? One of the cool things about Dr. Seuss books and Dr. Seuss in general was when he was rhyming along and would get stuck and couldn't think of a word that rhymed with his other little sentences, he would just make up a word. So this is my tribute to Dr. Seuss's made up words, and I made up a word called a swerve. And here we're doing a sinus lift. Actually, we're doing bilateral sinus lift for this case for eventual all-on-X type procedure. And a swerve to me is, you know, when you're lifting the floor of the sinus and things are going well, and then you have these molar roots, the three distinct top of the roots, and you're trying to be very careful with your curette and try to get into all those nooks and crannies and not create any sort of perforation, but sometimes you do perforate. And so when you're going up along the tops of these roots and you create a perf, that's when you swerve. So you'll see here that the video shows that I'm just got done elevating off the tops of these roots, and as we bring the curette up, it exposes a small perforation here on our video. And this is something that's easily repaired with a small BioExclude membrane. This works very well. See how the membrane goes on dry. Once you kind of place it into the position that you want, it'll kind of hydrate and do that saran wrap type cling wrap thing on its own. A lot of times you should probably leave things alone the way they are, but I tend to over manipulate them, and then you can see that I've dislodged the membrane. Rather than cut this out of the video, I thought I would leave it to, and this really shows you the versatility, if you will, of the membrane. The fact that it's very easy to be remanipulated without tearing or bunching on itself. Now I've positioned it in the area that I want over the perforation. A lot of times you'll get some bellowing then of the membrane once that's sealed off. And then we're going to go ahead and pack that with our sticky bone. This doesn't have to do with BioExclude, but I thought this was interesting because I'd used this this case to show some other highlights in a former presentation. And what I found out through working through this case was my AAOMS software gives me the ability to estimate out bone graft volume in maxillary sinus. So for those of you who use AAOMS software at all, if you place implants into the sinus, there's a button at the top there, one of those blue little buttons that will allow you to position the height of your intended graft in your maxillary sinus. Once you click that, then it will give you this sort of whitish cloud type area of the sinus of the intended graft. And it's real hard to see here, but there's teal numbers just above the graph to say total volume. And those volumes are cc's. Now, I think this is amazing technology, and I think this will help us in other avenues of innovation as we progress with patient-specific bone grafts and stuff. So I think while this is in its infancy in this software, it was interesting to share with you. Now, these volumes were pretty low. I think it came up total as 5 volumes. And what we ended up using for the bilateral sinus lift and some horizontal ridge augmentation in the anterior was 12 cc's. And this slide's really cool. And I thought, well, this doesn't really need to be in this presentation. It doesn't really give us more information, but honestly, it does give me information because I used 12 1 cc vials, when in reality, I could have been more cost effective and used the 2 cc. I could have used 6 2 cc vials. So sometimes just looking at your photos and your case documentations does sort of trigger you to do things somewhat differently next time around. I think that's what I'm always trying to do, look for ways to do things in a more efficient manner and to help me optimize my case outcomes. PostOp Panorax showing nice grafts on both sides. There's no graft extravasation, so I've gone ahead and sealed that area, and the patient goes on to heal real nice. This is a big case. I used 4 20x30 membranes and a 12x12. In fact, I think I got my BioExclude socks out of this case. And after the graft maturation comes along, we're able to use X-Guide with its new fiducial-free X-Mark protocol to place the 6 implants for the eventual all-on X hybrid prosthesis. Next chapter, we get it, we got it, we are starting to see, but can you help with an apicoectomy? So I typically don't do traditional apicoectomies, but I'll give you my two variances on apicoectomies. When you're setting up these immediate implants, especially in sometimes in the canine area, you'll almost anticipate a little bit of buccal perforation at the apex of the root, just the way that the bone is kind of shaped. And this is a case where I removed the tooth and did my implant osteotomies. And prior to placing the implant, I kind of felt down along the buccal wall, and I felt this little bit of buccal dehiscence. And I would have years ago dropped the vertical release and flapped this all out of the way to graft this, but I had kind of was inspired from a previous case a few years ago where I saw the apicoectomy scar at the bottom of a tooth that I was removing. I thought, why don't I just go through that old apico scar to kind of graft that apex? So that's kind of what I've been doing for cases like this. It gives you easy access to pack the bone graft around that area. It also gives you very nice visualization to ensure that your implant is beyond the perforation and still engaged in bone. This is something that's very easily grafted with like a half cc of allograft. You place a small 8x8 or 12x12 membrane over that area. You close it up with a couple chromic sutures, and it heals just fine. And notice we're still putting custom healing caps on. I think think it does a great job for canines, preserving that buccal eminence, if you will, and it's still maintaining sort of your gingival levels from your central incisor back to your canine. This is page just showing the pre to the 3-month custom healer to the 3-month custom healer being removed. We get very acceptable, very nice pink aesthetic outcome, if you will. This case, it's kind of in denial about this for a while, to be honest with you, and I kind of felt bad for this patient. She had seen me. She had a bridge on tooth numbers 23, implant 23 to implant 26. Now, the previous provider had some soft tissue erosion on 26. He had tried a few times for soft tissue closure that unfortunately was unsuccessful. Now the patient was very symptomatic and was looking for a second opinion, sort of something that could correct the situation. So I felt like the most predictable way to do this would be to remove the implant at 26, remove the tooth number 27, place an immediate implant then, and expand this bridge from 23 to 26 to 23 to 27. Now, the patient kept coming back. She was having off and on swelling in the vestibule during the 3-month integration mark, which I would treat with antibiotics. I didn't really appreciate, I think, the radiolucency around the apex of the implant, or else I was in denial about it. The implant torqued fine at the time of the 3 months, so she went on to have this 5-unit bridge fabricated, and she came back and she's like, Mike, I'm still swollen, you know, down here in the vestibule. What should we do? Now, around this time, I'd seen the compendium article that had come out about periapical periimplantitis, and I thought, okay, so that's what this patient has. She's got periapical implantitis, and then I got a CT scan the next time she was in, showing this radiolucency that was primarily confined to the apice of the implant. So in reviewing various treatment options, I decided to do implant ectomy, periapical implantectomy, if you will, where I exposed the buccal side of the implant. I had to unroof the abscess. You can see there was a little bit of bone loss that was tracking to the medial side. Now, what saved me here really was 2 things. First was this tracking didn't go along the side of the implant. It was separate. So the bony walls were still intact on the mesial side of the implant. The second thing that I felt like I had going in my favor to do this was I used, I believe, an 18 millimeter long implant. So I felt like chopping off a couple millimeters at the bottom of the implant wasn't going to affect the overall stability or long-term success rate of the implant. So once I had it unroofed, I did the apicoectomy, if you will, of the implant. I used a carbide crosscut fissure, cut right through it, cleaned out the area, grafted it, placed the 10 by 20 horizontal BioExclude in this area. They covered it with a patch of PRF and then sutured it closed. And kind of crossed my fingers. And afterwards, the 2-week mark, the patient was asymptomatic, which was good. And I scheduled her back for the 3-month mark. Hadn't heard from her in between. So when she came in at 3 months, she was asymptomatic. The off and on swelling had resolved. I got this Panorax at that point, and it looks like we're healing around the area of the abscess, and we still have bone intact on the mesial and distal wall of the implant. So I think in this case, it was the appropriate decision to do, because there's a lot of things that we would have had to deal with. Otherwise, we would have had to remove the implant. We would have had to deal with sort of remaking that 5-unit bridge. So I'm happy for the patient that we were able to make the right decision, at least for now, that this resolved their issues. It's kind of a last chapter here, but what about kids? Can you help those little turds? Can you help? Would you help when we remove the thirds? Now, in all fairness to Dr. Seuss, he would not call kids turds. He loved kids, but I was having a lot of trouble coming up with a word that rhymed with third. So the only thing that seemed to fit for me was turds. So I went with it. And what really like, or why I really enjoy working with BioExclude, not only their products, but also with the people who work there, is that they're really evidence-based driven to in terms of the applications of the product. And there was an anecdotal study, if you will, showing that the use of BioExclude membranes in third molar sockets decreased the amount of postoperative discomfort that patients were in. But the study was kind of not well done. There wasn't really a lot to kind of support it. So BioExclude reached out to me to say, hey, would you be interested in doing this study in a more formal avenue? And I said, yeah, I mean, that's great. You know, science is always awesome. So myself, along with Pete Mariner of Snoasis, set up this randomized controlled clinical trial, which we just completed a few weeks ago and run in my office for the last year or so. We enrolled kids age 15 to 25 with sort of routine impacted third molars. And we looked at the BioExclude application in basically two different avenues. The first arm of the study was where I would place the membrane, the BioExclude 10x20 as almost like a membrane over that lower third molar site, close it up. And we compared that with the non-membrane placed side. And that is the group here on the right, called without the collar plug. And we really didn't see a statistical difference when it came to kids reporting their pain on a visual analog scale. And this was carried out for 10 consecutive postoperative days. We did another arm of the study, sort of replicating more accurately in terms of this anecdotal study with the collar plug. And I would place the membrane deep in the socket and place a collar plug over top of that. And we would do this in a single blind randomized manner. And again, we didn't see much of a difference in our control versus our experimental group. And while we really didn't obtain or satisfy our hypothesis, if you will, I think it goes to show a lot in terms of the company that we still did this. And while the results weren't what was intended to really show that BioExclude makes a difference, at least the company knows now that using BioExclude in the third molar model, primarily for reducing postoperative discomfort, is not something that has been clinically shown to show improvement. So stamp on your smiley face and head out there. Where is there? Well, that's up to us, the doctors who now have trust. Trust in your company, Snoasis, the company which uses science to tell the story of you, the one they call BioExclude. This is these clinical publications are on the BioExclude website, the Snoasis website. Feel free to take a look at them. They're very well done. The product is very well documented. I can tell you that I've used the product in my practice for the last 5 years, and I think it's honestly probably one of the only membranes that I use for probably 99% of my clinical cases. It allows me to get the results that I want for my patients. I think it's very competitively priced. I think it's very easy to use, which is great. It's very easy to manipulate. As I said, you can cut it, you can move it around, you can take it out, you can get it all bunched up, you can iron it out. It's a very, very forgiving membrane from that standpoint. And remember, it's also you're also able to leave that exposed in the oral cavity, so you don't have to worry so much about a tension-free primary closure, which certainly has its advantages, and a couple of the different procedures that we use it for and that I've shared with you today. So on that, we're going to say the end. There's really two people that I really need to thank for helping me put this presentation together. One of them is my teammate here that works with me at Hartman AAOMS, and that's Vula Monk. Vula took all the amazing photos that were presented in this presentation. It makes it a lot of fun, and it allows us to document our work, which ultimately makes us better. The second person that did an amazing job with this presentation was Lauren Paul of Snoasis, and she did all the amazing cartoons and illustrations that we were able to show through this presentation. And Lauren, thank you very much for allowing me to share my vision in terms of what this presentation was for, and I'll tell you, you nailed it spot on, and I can't thank you enough. Speaking of thanking people enough, I would lastly like to thank BioExclude and Snoasis for allowing me to present here at their corporate forum at AAOMS 2021. I had a great time, and really look forward to hopefully presenting again for you. Thanks.